Welcome to Obesity, the Big Picture podcast. My name is Jackie Ilacqua. I'm president of Syndicated Healthcare Research here at Ipsos. Today we're talking about one of the most talked about topics in health right now, obesity care in the U.S. It's a subject that touches families, communities, and the entire healthcare system. And it's actually touched me personally as I lost 90 pounds back in 2012, before we even knew about GLP-1s and the impact that they would have on obesity. I'm thrilled today to be joined by two of the leading voices in the field of obesity and metabolic research. Professor David Allison, director of the USDA Children's Nutrition Research Center at Baylor College of Medicine, and Dr. Donna Ryan, professor emerita at Pennington Biomedical in Baton Rouge. Welcome, and thank you both for joining me on this podcast.
Thank you for having me, Jackie.
Indeed, it's an honor.
Great. Thanks. So let's jump right in. Let's start by talking a little bit about how the science in obesity care is advancing at lightning speed. GLP-1s like tirzepatide and semaglutide have already changed the game, and now we're seeing an exciting pipeline of new therapies from next-generation molecules to novel delivery methods. The question isn't just what's working now, but what's coming next, and how could that reshape the future of treatment? So maybe, Donna, we'll start with you. What excites you most about the next wave of obesity medications in development?
Of course, I'm thrilled to have these medications because they are about so much more than weight loss, Jackie. These medications have disease-modifying properties. So I believe they can change medicine. Our big challenge right now are the chronic diseases, cardiovascular disease, cancer, type 2 diabetes, on and on and on. All of the diseases that are filling our waiting rooms, many times the underlying driver is obesity. And these medications work not just through obesity, but through independent mechanisms to have effects on these diseases. So I am thrilled to finally have a chance to make a real impact on the health of people. But to have that impact, we've got to get these medicines in their bodies. And to do that, we really need access. We need better access. So right now, there are somewhere between 5 and 10% of Americans who are on these GLP-1s, but it needs to be much more. And so what I see happening is the next medicines that will come out, the next two, are going to be oral medicines. And I think this offers an opportunity to bring the price down. So I'm hoping that's going to be what happens.
Yeah, I couldn't agree with you more on all of that. David, is there anything that you want to add to that in terms of what excites you the most about the future?
Sure. I would agree with Donna that this is, in fact, a very exciting time. For those of us like Donna and myself who've been in the game for decades, it's been a long time of saying, we're trying, we have something, it helps a little, it's hard, you can lose 5% of your body weight, we'll tweak it, make it 6, with some new psychological technique. And suddenly now we can say, okay, that was a good try, and we'll still keep working on some of those things. But now we've got real medicines and real solutions that offer you help at the level you really want it. What's coming down the pike, I think, is two branches. I think there's a technological branch, which is more molecules that have additional and different effects, and in some cases maybe better effects or combined effects. And there's a lot coming. There are going to be things with different side effects, lesser side effects. There are going to be things that have anabolic effects. There are going to be things that work through different mechanisms of action so they can be combined. There are going to be things that preferentially preserve skeletal muscle while losing weight, and so on. Then there's a whole set of things that are not technological in the usual sense of the word. They're not molecules and so on. They're at most technological in terms of laws and policies and insurance plans and delivery mechanisms and websites and telehealth and so on. And I think a revolution is coming, I hope it is, that's some combination of changes in attitudes about who can get access to things, in whether these things should be seen only as treatments for people who have diseases or to prevent diseases, or are they lifestyle treatments for everybody who wants a lifestyle treatment. Where's the choice involved? Who pays for this? The distinction between the cost of the treatment and the value of the treatment. I think there's a lot coming, and I think it's time to really rethink our whole health and our approach to our lifestyles about optimizing our lives and not simply preventing disease. I don't want to just not get a disease. I want to live a long time and feel good.
I think we can all agree with that. That's it's an amazing sentiment. I think we've come a long way because, you guys have been in this business for a long time, but obesity for the longest time, people weren't even recognizing as the disease that it is, right? And the link between all of the other diseases that Donna talked about, including 13 different types of cancer that are linked to obesity, in addition to cardiovascular diseases and things like that. So I think we all share this level of excitement. I want to talk about access because it is so exciting, right? So 2025 is shaping up to be a landmark year in the US. Medicare is finally expanding coverage of GLP-1 medications. New drug pricing rules are shaking up how patients and insurers think about cost and access. But again, we already talked about, and it was mentioned before, that not everybody gets access. What does the Medicare expansion really mean for patients who've been waiting for these treatments?
What's important about Medicare is it's where Medicare goes, all of our insurers tend to follow in terms of policy. So, for example, a real breakthrough with these drugs was that Medicare approved the semaglutide treatment for cardiovascular risk reduction. This is the very first time that Medicare was going to pay for a medication that had an indication for obesity and reduction in your risk for a heart attack. Of course, you already had to have a heart attack or a stroke. This is to prevent your second one. But that was a huge, huge landmark. And what we've seen from there is that Medicare and other insurers are starting to approve these drugs in people with obesity with these other complications. So, so right now we have the complication of obstructive sleep apnea. So if you have an apnea-hypopnea index of higher than 15, you can get your tirzepatide paid for by your insurance company. So what tends to happen is happening now is that the payment for these drugs is coming around the disease indications. What we don't have is just Medicare approving these drugs for obesity, and that needs to happen, we think.
Watching the news or reading the news lately, we're seeing early moves towards direct-to-patient prescription access, right? Whether through pharma companies or government programs. We're seeing Lilly Direct, we're seeing, talk of Trump RX, which bypass traditional intermediaries. So, David, a question for you, or Donna, how do you see this shift reshaping the healthcare market in terms of cost, access, and patient outcomes?
I think there's more than one way this could occur. I think one way is to stay within still a semi-traditional model, which we see that these molecules, which are called medications, are regulated by the FDA in terms of who can take them or who can sell them, which ones can be sold. Then they must be sold usually through a prescription, through a physician, and there's an expectation that those people who have health insurance will be able to get these things paid for by health insurance because they're medications to treat or prevent diseases. There's an entirely different perspective, which is to say these are molecules. We don't have to call them medications. We could, but we don't have to. And they're available to people to choose to take with knowledge of what they're taking. Maybe sign a release form that shows that you actually understand things, right? We see in some ways the opposite thing happening with our political environment today with the vaccines, of some people saying, look, we want you to sign a release or something that says you understand the vaccine, which we used to want to push to you. Now other parties are nervous about pushing it to you, so sign something. Here we might say, we didn't want to push this to you previously, but you've been asking for it, so you can have it if you sign the release that shows you understand the risks. But we would treat it as a molecule, not as a product, not necessarily as a medication for which your physician and the FDA are the gatekeepers and for which you have to have a disease or a health issue to take and for which you must expect it to be covered by your insurance. It's a product like any other product. If you want it, you pay for it. And then I think, of course, there's the hybrid model, which might say if you have a disease and your physician thinks you need it, you can get it as a prescription, and then maybe it is covered by some third party. But if you want it and you don't have a disease or something, then it's a lifestyle enhancement, and you can pay for it, but you can still get access to it. And I think we're going to see lots of different combinations of this, but I think there's going to be an open-mindedness coming. It already is coming. People don't always talk about it publicly. Publicly, people often are more, at least leaders, a little more conservative. But privately, I talked to one member of Congress who's a very astute person. I won't say that person's name, but who's a very astute person who is neither diabetic nor obese, and said to me, I'm taking a GLP-1 agonist because I want to live longer. I talked to a billionaire philanthropist who's very astute and smart, and said, I'm taking it even though I'm not diabetic or obese because I want to live longer. And I know scientists who are doing that. And so people with power and money and education are making these decisions. And I think that's fine. Let them pay for it.
I have slightly different opinion on that. I think these are powerful medications. They're serious medications, and we need to take them seriously. So I see these medications sort of like being answered prayers. David and I worked a long time in the field, not really being able to produce much weight loss or really, in truth, much health benefit. It was a slog. And so all of a sudden, my prayers are answered. I have medications that can produce robust weight loss, that can improve diabetes, cardiovascular disease, that can reduce deaths from COVID. We demonstrated that in the SELECT trial during the COVID pandemic. The people on semaglutide had fewer COVID deaths. Oh my goodness. These medications are incredibly powerful. But I think, like answered prayers, sometimes more tears are shed over answered prayers. These, the physiology of weight loss is not anything to play around with. We, in losing weight, we know there are profound physiologic changes in the body, and it can be dangerous. It can cause acute problems. It can cause dehydration. They're just profound. When you stop eating, there are profound changes that can occur. So I worry about that. I worry about too much weight loss. I worry about loss of bone and muscle, particularly in older individuals who are taking these medications for their disease modifying properties. So I think these, so for me, I don't think that we should be in the Wild West where everybody gets to decide, hey, I want to take this and out of my way. I think that regulation of the use of these medications is important. It's important for public safety. So I have a slightly different take than David, but I do agree with him that our system of paying for medications is really, it's a mess, and we must change that. There are too many middlemen involved in this. And so what tends to happen is we get these ridiculous list prices, and then there are all of these rebates and coupons that occur. That has got to stop. Look, when penicillin was discovered, that didn't happen. They put a price on penicillin and people paid the price. And that's what needs to happen now. I'm very hopeful that with the first of these medications that is an oral agent that's not a peptide. Peptides are harder to produce. I'm hoping that this first medication, orforglipron, will come out with a realistic price. And I personally think that realistic price is about $200 a month. I think if it were $200 a month, we would come up with a way to pay for it with our insurance and copays. And we've got to stop this rebate insanity, which essentially all it does is cut in a lot of middlemen.
It's like buying a plane ticket. You never know what you're going to get.
Isn't that the truth?
Donna is not only more knowledgeable than me about patient care, but also about answered prayers. So I want to switch the topic back to something you started to ask about a little bit earlier, and that's two things: skeletal muscle loss or body composition changes, and secondarily, treatment response heterogeneity, or the idea that not everybody responds the same way to the same treatment. Let me address both of those because I think both of those are areas in which there is a great deal of loose dialogue based on limited evidence that is taken up as though it is true, even though it is either not or has not been shown to be true. So the first point involves the skeletal muscle loss. So I think the narrative is, or at least has been for some people, these drugs produce excessive skeletal muscle loss. It's excessive in that it's problematic and that it's more than one would expect given the amount of weight loss and more than one would expect with other methods. That's the narrative. The reality is very few studies have measured skeletal muscle. They've measured lean body mass or fat mass by DEXA. They're highly correlated, but they're not identical. Second, you don't need as much skeletal muscle when you're smaller. So if you're a 400-pound person and you have to go up a flight of stairs, and you can still do that, and there are people who do that, you need big calf muscles. When you are a 150-pound person, you don't need such big calf muscles to get up a flight of stairs. So some loss is normal. There is no evidence that I am aware of in either mice or humans that shows that for any given amount of weight loss on a GLP-1 agonist, the amount of skeletal muscle loss is greater than for an equivalent weight loss not on a GLP-1 agonist. There's even some evidence, some came out in a mouse recently, that suggests the exact opposite is true. And many people are studying this now in both rodents and humans. So I think while we can't exclude that yet, I would put that in the not so well supported, urban legend kind of category for the moment. Now, that doesn't mean that we don't want to prevent skeletal muscle loss anyway, right? So if somebody were to say to me, would you like more skeletal muscle, even though you haven't lost a ton of weight with the GLP-1? Yes, I would. I'd like to be stronger and look good and be healthy for a long time, and I have reasons to believe that might be good, although I just put up a LinkedIn post saying, I think it might be good, but, there's reasons to question it too. It's not so simple. And so that's where the anabolics come in. And I think what we're going to see is agents that combine a weight-losing effect with agents that have an anabolic muscle-gaining effect, and that will be the foot in the door. And then the FDA will approve that. And then Donna's perspective as the healthcare provider and mine as the libertarian will debate it out in the literature. And the question will start to be, why do I need to be losing weight to want or merit an anabolic agent? What if I have Duchenne muscular dystrophy or Alzheimer's or Parkinson's, or I'm just, my 87-year-old mom who's just could use a little more mass. And then soon it will become, it's not even that. What if I'm just a 20-year-old person who wants to look better or perform better in sport? And I think that will come. The bodybuilders will start immediately. They won't wait for the cultural revolution. They will be part of leading the cultural revolution behind the scenes. But I think that's something that's coming. And I think it's not a bad thing. The second thing is the treatment response heterogeneity. We hear it said over and over, not just with GLP-1 agonists, but with nutrition, with exercise, with whatever. We don't all respond the same way. I heard a very astute podcaster say yesterday, you show me 50 guys on an exercise protocol, and I'll show you 50 different responses. And it's a state of an article of faith. Can you really show me? What people see is differences in outcome, right? Donna goes on the treatment, she loses 10 kilos. I go on it, I lose 5 kilos. You go on it, you gain 2 kilos. And someone says, look at the difference in these responses. And I say, no, those are differences in outcomes, not responses. If outcomes and responses were the same thing, we wouldn't need control groups in studies. The reason we have control groups is because responses and outcomes are two different things. So what we really need to look at is different designs that point out treatment response heterogeneity. One of my postdoctoral fellows, Dr. Reddy, just submitted a paper in which we looked at acute effects of multiple things, including GLP-1 agonist drugs, where we have special designs where we can look at the treatment response heterogeneity. And in some cases it's there, and in some cases it's not. So sometimes we all kind of do respond about the same way to certain things. If the treatment is decapitation and the outcome is verbal production, we kind of all respond about the same way.
David is absolutely right. It's very difficult to measure muscle change. And, the very best measure is this rare test that's done. It's the D3 creatinine dilution. And David's center in Houston has the ability to do this. I hope he'll be leading some studies on this. So what we're usually measuring is fat-free mass, or lean mass, which is we take the bone and the fat out, and what's left is lean. But it contains other things besides muscle. And especially as we age, the proportion of muscle in there changes. So to me, I'm not real, and I do not think that there is a special effect of GLP-1s on muscle loss. I do believe that we need to be careful in subpopulations because weight loss, which inevitably produces loss of lean and fat, that weight loss in older individuals can be problematic. And so I know this from the good old days of Look Ahead, where we did this lifestyle intervention in older individuals. They were 59 at the start of the study. On average, they were 69 at the end of the study. And we had a higher rate of frailty fractures in our intervention group. They only lost, the first year they lost a little more than 8% below the control condition, but over time they regained. And at the end of the study, they were only down about 4.5% from where they started. But even that modest weight loss, they had an increased risk for frailty fractures, and I worry about that. So I worry in older individuals, just any kind of weight loss, we need to be careful about. And so that is an issue. I think we're going to be more and more interested in what happens to bone too in that older population. So for the young people, look, I'm not worried. If you have obesity, you've got increased muscle mass because you're carrying around a lot of weight, extra weight. It's like weight training. I'm not worried about you if you're 30 or 40. I'm worried about you if you're 60 or 70 and losing weight. So I think it's a very rich area for research. I'm looking forward to working with David on addressing those issues. And look, what's happening in the biology of this is exactly what's happening in the biology of body weight regulation. Look, our bodies regulate the amount of fat that we have. Our bodies regulate the amount of muscle that we have. Our bodies regulate our red cell mass. We have a hormone, erythropoietin, that tells us what our red cell mass ought to be. So we really need to understand the body composition regulation a lot better, and we're going to do that.
And I would say, we saw a little bit of a revolution with respect to our perceptions of body fat, probably in the early 90s, I would say, where the prior perception, I think, was body fat is two things. It's a mechanical load, so it stresses your joints and your heart because you're carrying it around, and it's a storage place for energy, and that's it. And then I think in the 1990s, people started saying, actually, no, seems like it has some immune function. It also seems like it secretes a lot of stuff. Some of that stuff is good. Some of that stuff may not be so good. And it's a secretory organ, though. It's a very active organ that's involved in, the whole body, regulating everything's connected to everything. And this richer view. I think skeletal muscle has been seen a little bit more as, again, it's mechanical. It's the thing that makes you move. And it's important for that. And it's a little bit of maybe a sink for glucose And, it's a way of storing that. And that's sort of been about the limits of it. And now I think people are saying, no, there are myokines. Just like we said, there are adipokines, there are myokines. There are things that muscle secretes. Some of those things go to the brain. Some of those may affect the hypothalamus, or not may, do. Some of those may affect longevity, appetite. Some of those may have good effects. Some may have not so good effects. And I think that richness is upon us. We need to really begin to understand that whole network.
David, I really liked your comments about variation in response, variation in endpoint response. And I think one of the most interesting things that's happening is understanding that the weight loss is not always tied to the other effects of these drugs. So, for example, in that SELECT study, the weight loss was not required to have the benefit in reduction in cardiovascular events. So the MACE, the major adverse cardiovascular event, that rate was the same whether you lost weight or not on semaglutide. So it's beyond weight loss that these drugs are acting. And I don't think we fully understand that. So in your to-do list of better understanding variation in endpoint response, throw that in there, please.
Yes, ma'am. And in fact, I would say it's also true on the psychosocial outcomes. So to the extent that the person says, I took this drug and the quality of my life has improved, or I'm more pleased with the outcome, however we want to say how we define pleased with the outcome, we might start to say, how much of the fact that you're pleased is due to the weight loss you achieved? How much is due to the fact that you have less food noise, that tickling in the back of your brain that's constantly irritating some people, and suddenly they didn't even know it was there, they just thought it was life. And suddenly,
or drinking less, or smoking less, or gambling less,
or looking better, or mood improvement, or whatever it is. So I've talked to people, I've heard from people who have said, even if I never lost a pound on this, the reduction in the food noise alone would be such a wonderful outcome that I would take it just for that. And I think we need to start to parse that a little bit as well.
Yes, I agree. It took me a long time to really understand what they were talking about with food noise, because I love thinking about food. I'm a foodie. I have a collection of cookbooks. I like giving dinner parties. I like going out to eat. Show me a Michelin star and I'm on it. So I love all of that, but this is different. What our patients are talking about, what they're describing as food noise, is not all of these pleasurable experiences that I'm having. No, these thoughts about food they're disruptive. They're interrupting their lives. They're unpleasant.
They're exhausting.
Yes.
You have food music. They have food noise.
That's right.
I want to circle back for a minute, because I want to talk about access, because I think we're all on the same page talking about the benefits of GLP-1s and the impact that they're going to make in obesity and lots of other diseases, right? But access isn't equal. Right. So we've been talking, and Donna, you talked about this as well, right? You talked about the discounts, you talked about the rebates, you talked about, how do we go about getting these drugs? And I personally, and I'm sure you guys know as well, I personally know people who, are qualified to get the medications, not just because they're obese, but because they have fatty liver disease or because they have sleep apnea, who are not getting approved for the drugs, right? It comes down to insurance. So my question to both of you is, who's being left out of the obesity care revolution and why? Are the current insurance and pharma models sustainable? And Donna, you already talked about this, but there's definitely still a lot of people getting left out, even though we're making strides. And who are those people? It can be based on race or gender, where they live, income, all of those things.
There used to be a pretty good program under Obamacare to get people who are underserved access to medications. And so that was it was named something like the 340B or something like that, named for the statute. And that was a pretty good way to get medications to people, including these drugs. But that seems to have gone away. Our policy about this is it's not uniform. It's not uniform across the United States. There's a lot of variation about what states are deciding. Your insurers make decisions based on who knows what. In Louisiana, the Cadillac insurance is oil and gas, and Ochsner, the big hospital system. And I think they cover these medications because they have a competitive advantage in getting the healthcare workers. But so it's very much a patchwork, and it's maddening, Jackie. It's there are people who can pay out of pocket, and that has gotten down to about $500 a month for the two available GLP-1 based medications. But for many people, that is unattainable. That is just unattainable. Um, there And how to fight that, I don't know. I truly believe that part of the problem is this system we have of negotiating prices that includes these very large companies called PBMs. And so what the PBMs are doing is they negotiate with pharma to reduce the list price of all the medications. So they give the employer a deal. So your employer signs up with whatever PBM is going to deliver your medication. And then, at the end of the year, the PBM shares part of the rebate, the coupons, whatever, back to the employer. The employer does not put that against the health insurance. He puts it against his bottom line. But, if you have a business and all of a sudden the PBM says, hey, here's $13 million, that makes you happy. happy. So it's a system that's where the price of the medication it's impossible to determine, and it's shrouded in secrecy. They're not allowed to tell you what anybody is paying for anything. So I strongly believe that shining a light on this, transparency is important. I do believe that this ridiculous list price ought to go away. I think the price should be the price.
And I think if you look at, we were talking earlier about the link between obesity and so many other diseases. And if you look at the overall cost of treating people with cancer, right, that maybe could be preventable, right? A certain cancer could be preventable, or other diseases that could be preventable. If you look across the whole cost of treating those people versus the cost of covering the GLP-1, I think we're kind of looking to, maybe the insurers are looking to individually at the cost of one medication as opposed to the cost of treating a person's health over their lifetime, which is something that we've all been talking about, is getting healthier in the future.
Jackie, when I was in medical school, I was fortunate to be taught by senior physicians, and they told me what it was like before the antibiotics were discovered. And they talked about people dying of tuberculosis, and then streptomycin saved their lives. And they talked about when penicillin came out, how difficult it was to get. But it was not difficult to get because it was expensive. It was difficult to get because it hadn't been produced. So I really think as a society, we must address this.
I agree. And I think we should get away from thinking about the value solely in healthcare savings. It's always kind of irritated me with obesity that people say, look, let's try to demonstrate that the amount of money we'll save in healthcare by treating the obesity will be greater than the amount we'll spend treating the obesity. And I think, I don't know, if you had pancreatic cancer, would somebody say, we're only going to give you treatment if the cost of the benefit, in reduction in healthcare exceeds this? It's not going to. And yet we think you're entitled to a life and giving it a try. And similarly, there are other things particularly when you start to think about this, not just as, again, disease treatment or disease prevention, but lifestyle enhancement, longevity enhancement, optimization of life. Right? Some of us drive vehicles that are safer, bigger, more enjoyable than others. And guess what? You pay for it. And you say, that enhances my life. And it does. You don't have to show that somehow there's a healthcare savings to have your safer or, to drive your Volvo and not your, I don't know what, your Pinto.
Yeah. So I think, trust is a big issue in obesity care, right? So when we talk about obesity care today, it's not just about the access, it's not just about the innovation, it's about who we trust. Patients are hearing messages from doctors, from drug companies, from government, and from the media. And you talked about this already, both of you, Donna and David, about the noise and kind of misunderstandings as because of the noise. So not all voices carry the same weight, right? And we know that. So who do you think, when it comes to obesity treatments, who do you think patients are trusting most now? Is it healthcare providers? Is it government? Is it pharma companies, media, social media?
Well, surveys of trust in general have shown that within the United States, and I think this is probably true worldwide, trust in general is down, but it's not down equally for all groups. So trust in Congress and the media is the lowest, and it's sunk the most. Doesn't matter if you're on the political left or the political right, people don't trust the media. They don't trust Congress. On the other hand, trust in nurses is very high. Trust in nutrition providers is higher than nutrition scientists, according to data from the Pew Charitable Trust Survey instruments. So it really depends upon, the category we're looking at. Trust in nurses, healthcare providers still is pretty high. And when you get to the more media statements about trust in particular aspects of science, we often hear this anti-science movement in the country. I don't think that's true at all. I don't think trust in science as a process is down. Even the people that many of us in mainstream science might say, I don't know if that's science, the Gwyneth Paltrows of the world or whatever. I hope she doesn't sue me. But in any case, they're still talking about science, or at least purportedly are, right? They're not saying tarot cards is the way to go. They're saying this thing has this molecules. But the question is, which scientific finding do you trust, which scientific study, and which person? Some people think Gwyneth Paltrow. Some people think RFK. Some people think Tony Fauci. Some people think the FDA. So there are great differences in who we trust. There are great differences in which studies and findings we trust. And I think the American public needs help with that, not with this idea of saying you don't understand science, you have to trust science. No, we have to things that are purported to be science, how do you sift through it?
Great. Thank you so much, David. I want to just look to the next 5 years and ask you, what do you think the landscape of obesity care will look like? From access to medications to patient experience, trust in science, all of the things that we talked about. Which changes do you think are going to have the biggest impact on patients' day-to-day lives? What's going to happen?
First of all, I think we will solve the problem of getting these drugs into patients because as a society, we have to. This can transform the chronic disease burden of the 21st century. Our major challenge in this century are the chronic diseases, and these drugs can transform that. And we're going to solve this problem. We're going to get these drugs in our patients' bodies, and we're going to do that. There are going to be, in 5 years, there'll probably be maybe 30 medications in the market. Some of them will be oral, some of them will be injectable. They'll have different mechanisms of action. If you don't respond to one, you might respond better to another. If you have more side effects with one, you might have fewer with another. Some of them will be given monthly or maybe even less frequently. There'll be oral medications that are safe and that we have a lot of evidence about their safety. And we'll have affordable medications. I think this is going to happen. I think one of the biggest challenges is a skilled workforce. We do not have a skilled workforce out there right now. Only about 14,000 physicians are writing 50% of the prescriptions. We've got a very small writing class of physicians, and that means the others, well, there are a lot of barriers to writing, the prior authorization, and there's so many hurdles to writing a prescription for these drugs that they're not widely prescribed. So in volume. And so we really must develop a skilled workforce. I think telehealth is going to be a part of this. And I think we're going to have very good telehealth companies. I think these companies are not just going to be a quick and convenient and easy way to get your medication. I think they're going to track your progress, and I think they're going to have a lot of guardrails in place for safety. And I think they are going to have, if something bad happens to you, they're going to be on it. They're going to know about it. They're going to be tracking adverse events and getting you the very best care. So I think telehealth has the potential to be to really solve that problem of the skilled workforce. And by having some really skilled people and some very good lifestyle and other recommendations to go along with the treatment. So I see that happening too. I think that's going to emerge. I think that what I really want to see, this is in my wildest dreams, I want there to be fewer stents placed. I want there to be fewer dialysis centers. I want to see those chronic diseases coming down. Those 13 kinds of cancer, Jackie, that you mentioned, I want to see fewer cases of those. I want to see fewer people dying of COVID or any other infectious disease because these medications can improve your immunity. I want to see those other things happen too. That's my dream.
I agree 100%. And I will add, just in a very short time, but the anabolic agents are coming. I would say it's going to be greater availability. And it's going to be a change from thinking about healthcare or the use of medicines as just disease treatment or even disease prevention to lifestyle optimization, longevity promotion, fitness. And so the very realistic questions will start to be, if I'm a 20-year-old who doesn't have diabetes, hypertension, obesity, hypercholesterolemia, but I know what's coming. I'm an American. I know what's coming. It's only a matter of time. Why don't I start with a low dose of an SGLT2 inhibitor, a GLP-1 agonist, a statin, a PCSK9 inhibitor, et cetera, when I'm 20, if I want to optimize my life? And I think those questions are coming. And I think in some cases, the answers will be yes.
This has been such a fascinating conversation. I want to thank you, Dr. Donna and Dr. David, for sharing your insights. I think we all agree that obesity care is changing fast. Today, we've explored how the science, the policy, and society are all shaping the future. To our listeners, I want to thank you for joining us on Obesity, the Big Picture podcast. And until next time, stay curious and take good care.